All right, I'm going to go ahead and get started. Good afternoon, everybody. My name is Melanie Escher-Blair, and I'm with the Arizona Telemedicine Program and the Southwest Telehealth Resource Center. And welcome to our webinar series, Improving Access to Quality Medical Care. We are going to go ahead and move forward here. I'm going to start with the land acknowledgement. Here with the University of Arizona, we respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So again, welcome everybody. The Southwest Telehealth Resource Center, we represent the Southwest region. We've got Arizona, New Mexico, Colorado, and Nevada, and the Four Corners area. Any other HRSA grantees and all other participants, again, welcome. Arizona Department of Health Services and the Arizona Telemedicine Program, Southwest Telehealth Resource Center. This is a free webinar series. We have many others in this series, especially ones that Dr. Klotz has done. You can check out those past webinars on our website. So as you join today, a couple of tips. Your microphone and your camera were off, but we are going to be using the chat feature. So down in the bottom of the screen, of the Zoom screen, you'll see the little chat box. You can go ahead and open that up. And if you have any questions for our presenters today, please go ahead and type them in there. This webinar is being recorded and it will be available on the ATP website later. The URL is there, and I will put it into the chat a little bit later. There's also an evaluation that will be populating in a background web browser. Please go ahead and fill that in, and we'd love to have your feedback. Quick disclaimer: the opinions expressed in the presentation and on the following slides are solely those of the presenters and not necessarily those of the organization sponsoring the webinar. And the organizations do not guarantee the accuracy and reliability of the information provided herein. So I'm going to start with introducing Dr. Klotz. He's a professor at the University of Arizona College of Medicine. He's also the medical director of the Arizona Telemedicine Program, and he's wonderful to work with. And he's going to go ahead and start off today. I'm going to go ahead and stop sharing. Dr. Klotz is going to go ahead and get his file set up. He's got a little bit of a delay. He's attending a little bit further away from Tucson today. And so he's going to have his camera on to start with, and then he's going to turn the camera off to help with his bandwidth so that we can have a little bit clearer audio. These are the types of things we do when we're working with our technology. Make sure that we can get the best information to you. So as he's getting this all set up, again, if you have any questions, please use the chat feature, and I will pass the mic on to you, Dr. Klotz.
Thank you, Melanie. I'm going to extend my bandwidth, so to speak, by muting, if I can find where to mute now, or not mute, but turn my video off, excuse me. Well, thank you very much, everybody, for joining us this afternoon. I think we have a very important program to present to you, and it's one that I am certainly really excited about and passionate about, and so are Larry and Krystal. So we've entitled this Do-It-Yourself Telepharmacy, How Actually to Do It. Now, I'm an infectious disease physician, and clinically, I've spent all my years mainly taking care of HIV patients, and that's where I've encountered Larry and Krystal over the last 6 to 8 years. We've worked very closely, and we've, in the last couple of years, almost exclusively on telemedicine, doing clinics for the Department of Corrections and throughout the state of Arizona. And this is where we kind of learned what to do. And I think telepharmacy is something that's really needed urgently and in a big way. This, beyond anything else that physicians can do or pharmacists, this alone would improve patient care probably twofold. You have this face-to-face interaction with a pharmacist, even when they're miles away. The problems can be addressed proactively by setting up regular telepharmacy meetings between the patient And as whether you're a physician or a pharmacist, you know how important today the pharmacist is. For example, in the HIV arena, I mean, the pharmacist is the most important member of the care team because they're delivering the most powerful medicine. It's expensive. There's a lot of complications with it. And whatever your specialty is, you can see right away that you could do things with telepharmacy that can't be done currently. And it adds really a dimension where you can just check with a patient on a regular basis. And you can imagine, I mean, whenever I go up to CVS Pharmacy and pick up my medicines, they say, well, have you ever had this before? And no, I haven't got time, you just drive off. Well, if you call these people up, put them on the Zoom line, look at them in the eye, the pharmacist does and says, well, what do you actually have? Well, they'll go to their little medicine cabinet and pull out their chromium and their iron and their this, that, and the other thing. So many of the things that we currently schedule patients into brick and mortar clinics, we've learned can be handled easily with telepharmacy. This includes like chronic antibiotic administration. There's no reason for these patients to have to come into the hospital to just stare at their PICC line, which they can tell you is clean anyway, and then things that you could just tell them on the phone or on the connection. There are patient problems that in the physician's practice that really they're best handled by pharmacists. For example, in HIV and diabetes mellitus, this can be successfully addressed really most frequently by regular visits with a pharmacist. And it actually turns out to be cheaper, as you know, because they don't end up coming to the hospital with DKA or having missed their HIV medicines for 6 or 8 months. And then you have to do an extensive workup, which is a lot of blood work, and in the case of diabetes, a lot of in-hospital care. The physician needs, of course, to overall see the diagnosis and the direction of care of the patients, but you don't have to see them very often. I see my HIV patients once a year on telemedicine. The pharmacist can charge for their services. I know everyone's going to say, well, wait a minute, how do I do that? And without stating all the legal ramifications and so forth, I think what can be worked out is how and who's going to do it and why it's important. And then it becomes apparent that, salaries are going to have to be changed a little bit, or how much is committed to different projects within a person's professional sphere. And honestly, it's just for those physicians who might be on the line, it's just safest to have a pharmacist check your orders. With Larry, on our Department of Corrections and HIV, I let the pharmacist manage the HIV medications. They're best capable of doing this because there's so many drugs that I don't even know about anymore that may or may not have interactions with the antiretroviral drugs. And so I would urge physicians to find a pharmacists that you can work with, friendly pharmacists, most of them are, and then enlist them to do part of your care, or perhaps half of what you're doing in brick and mortar clinic. Let the pharmacist do it by telepharmacy. And honestly, a physician is improving their care if they start a telepharmacy clinic. And Larry and Krystal are going to talk probably a lot about HIV clinic or use of drugs for HIV, but that isn't the point of this webinar. It's really to give you an idea of what we do so you can reach into your experience and say, I think I will do this. I'm going to set it up this way. I'm going to suggest to the hospital that we do this. It's what's most upsetting to me is that since the epidemic is waning, now all the hospitals want to throw the doctors, just like they always do, back into the clinics. It isn't necessary. And much of this can be done by telemedicine. And although we used a lot of it during the epidemic, it's actually waning. It's gone to half of its use, which it was before. So I'm going to turn this over to Larry and Krystal, and I think they've got a lot of information to share with you.
All right, we do. We have a bunch we can talk about with you today. So hopefully we get through everything. It's always a challenge. It seems like we never quite pull it off. Let me get our chat box open here. So as we go, if anyone has questions, type them into the chat box. I do have the window pulled up here, so hopefully either Krystal or I or Dr. Klotz can address your question as we get there. So unfortunately, I do feel like we're notorious. We always push this to the last minute. So we'll try to be better today. But certainly the emphasis on this presentation is that emphasizing what Dr. Klotz has talked about pharmacy having involvement. It's really stressing that if you're here, you can take part in telemedicine. None of us have undergone any sort of rigorous training to become telemedicine specialists. I mean, I think like most of y'all in the audience, when COVID hit, everything got thrown for a loop and we all had to figure things out quickly and in a way that we could do this safely. The other thing that I think is worth highlighting is this is not our sole job. So I mean, we're still doing numerous other roles in addition to this telemedicine, both to emphasize that depending on the practice you want to implement this telepharmacy or telemedicine practice in, you don't necessarily need to see that as a subtraction from what you're already doing. This ended up being a rather seamless transition for us in terms of doing this in addition to everything that's already going on. What we discovered too, the last point, and I'll show a couple of pictures here, we've been able to do this using tools that you can go and buy at any Target or Walmart right now. I mean, in terms of the accessibility to this technology, the time has never been better than right now. And quite honestly, in terms of affordability, it is not bad to get this going. All right. So our definition too of telepharmacy, there is already plenty of programs in existence that are just a direct dispensing counseling that you see with retail pharmacies, which does, of course, fall under the banner of telepharmacy. But where we're looking to really elevate and take this to the next step is the clinical aspect, employing clinical pharmacists to co-manage various conditions. Already you see many providers that have collaborative practice agreements or standard operating procedures with pharmacists. They can help alleviate some of the burdens that they're facing in terms of managing some of these chronic conditions. And we will get into some possible ways that this can be done, as well as suggesting one unique way that we're looking to implement, and that's PrEP, or pre-exposure prophylaxis. Now, if you've been to any of our other webinars, we do a much more in-depth series about PrEP, about how we do HIV telemedicine. So I won't go into a ton of detail there, only to highlight the relative ease at implementing something that's brand new. And then, of course, we'll talk a little bit too about improving transitions of care. One way is through potentially bedside counseling via telemedicine, but it's making pharmacists more accessible in the inpatient setting to both providers, specialists, having that literally, essentially, a pharmacist in your pocket that you can go to if you need to address some of these issues. So just to give a little bit of our background, we've already, had our bios read. It's again, just to emphasize, we're not anybody special when it comes to doing telemedicine. This is just something we picked up or Dr. Klotz bullied us into. I can't quite remember sometimes. but basically taking part in telemedicine and getting to be a part of this. My background, straightforward, I completed infectious diseases residency in pharmacy, and I went directly into this clinic, the Peterson HIV clinics, managing HIV as part of a collaborative care approach. So we're basically taking a model that we're already implementing in the brick and mortar clinic, which is a physician, a pharmacist, and a coordinator seeing the patient all at the same time, and translating that to telemedicine. So I'm going to turn it over to Krystal, who can talk about her unique background and how she's bringing that to our telemedicine service.
So my name is Krystal Fimbres, and I've actually been with the Peterson Clinic for 6 years. I work as the early intervention specialist, so I am the first point of contact for newly diagnosed patients as well as patients who are transferring from out of care. Previous to this, I actually worked for the health department in Pima County, so I did HIV surveillance for the last 6 years, linking them to care, doing partner notification and partner testing, which goes to show, like Larry said, that you don't need any background or training to do this particular job. It's more being able to multitask and just being familiar with different operations, which makes it easier. I started doing telemedicine with Dr. Klotz and Larry almost 4 years ago, so we did this 2 years in person, and then when the pandemic hit, we had to go remote. And thinking it was going to be a hard transition, it actually was very easy to do because we were all remote already. So it's just figuring out the timing, getting all the electronics to work. But other than that, it is the easiest process to go ahead and transition into.
All right. So then we're going to talk a bit about our personal experiences with our telepharmacy practice, our telemedicine practice in Department of Corrections. So basic needs, I think most of this goes without saying, although it cannot be stressed enough, a reliable internet, as poor Dr. Klotz can vouch too, is having a reliable internet that's not crashing on you. So we've also had to become familiar with, all of us have cell phones that we can use as hotspots if, for the worst occurs and we lose complete internet access, just having that backup plan as needed. And of course, if you have the access to it, if you have a site where you can go nearby your current place of work or just another office, that's all you really need. As far as telepharmacy is concerned, we don't really need fancy high-tech cameras to do this. What we're typically using for Department of Corrections are cameras that are, well over $1,000. But these crazy things, you can also remotely control them from afar. You can zoom in. They're extremely high quality. You can look at the atomic structure of whatever the heck it is you're wanting to look at. Nothing so much that we're needing for pharmacy. A simple webcam will do, which is why now targeting individuals who have phones, it's very easy to communicate with them through telemedicine. We don't need a lot of high-tech stuff to really get that done. Now, of course, technical assistance is, I think, one of the big fears in implementing these telepharmacy and telemedicine practices. Now, what we've discovered is there is some learning curve that's going to be involved with this for sure. So problems are going to arise as they do in any setting. And I think a lot of hesitance on some providers' portion is actually just running this thing and getting it going. And to be fair, there are frustrations involved, but I can honestly say once we figured out the kinks, when COVID really started to hit hard, we've been up and running with no issues, and we have a number of fallback plans in case something happens involving nothing more than the technology you use every day to live your life and participate either inpatient or outpatient clinics. Now, lastly, this is the trick, is depending on what sort of a program you want to implement, having access to those patient records. And I'll let Krystal talk a bit more about how she does that. That was also something that had to change, and that actually, I think, was a blessing in that we just further converted everything to digital and truly set our telepharmacy clinic up to be just absolutely in the ether. Everything can be done from anywhere. So a day in our clinic, admittedly, it is an unusual setup. I don't think a lot of providers are quite doing it this way, but we're seeing various patients through a number of different correctional facilities throughout Arizona. So patients who otherwise would not have easy access to specialty services we're able to fill that gap. They're brought into usually just a regular room, not any different from what we're in right now, a regular visit room. And the patient's put in front of a camera. Now, depending on the site, these cameras could be much higher tech than others, but in some of these instances, we're even able to remotely control, as needed, the camera. And again, I think part of the key piece of this in the telepharmacy model is that you can implement where everyone's being seen by all of these providers at the same time. We have Dr. Klotz, we have myself. Krystal even can participate in this. I either have her in an earpiece or she's in the visit to help connect some of these pieces up. And again, I'll leave it for her to describe all of that that goes into that, in case for your practice, if you're considering this, you want that extra touch that can help manage some of the logistics behind this. Now, my role, of course, reviewing medications, which depending on what we get from these correctional facilities can be rather abstract. And especially when we're dealing with HIV, thankfully with the evolution of care with HIV, not a lot of major game-breaking interactions that we're seeing. But the ones that still come up are wildly deceptive. They're, I guarantee you, overlooked by every provider. And admittedly, it's no real fault of their own. Some of these interactions are frankly bizarre. And they're not ones you would ever in a million years think this could be an issue. For example, nasal steroids and certain HIV medicines are a potential recipe for disaster, and that's often overlooked. The other key piece of this too is, again, depending on the practice you want to implement, staff is present right there so that we can very quickly recommend, potentially institute some of these changes. So with our telemedicine practice that we're doing, probably 50% of it is HIV management through these facilities, and 50% is general infectious diseases consults. So oftentimes an issue could arise or something urgent needs to be made. We can communicate with the person on site and implement that change right away. And I highlight that more to emphasize in an inpatient setting. This is also something that can very quickly be done, with the exception of, depending on your inpatient setup, that pharmacist can very quickly, directly implement that change and be assured that it is correctly entered in and accommodates whatever it is that's causing the issue. So these are a couple of goofy pictures of us from pre-pandemic times, lest we forget what life was like before then. You can see our smiling faces. That was soon to change in February of 2020. But we had a dedicated space for telemedicine. And this admittedly is what also set us up for the theory that maybe you needed a lot more to start doing this practice. Now, that is not at all to say that this was not awesome. This was state-of-the-art stuff we were doing with telemedicine. In that left picture, we had two massive monitors where the patients were on there. The webcam, if you can see it right here, is one of these incredibly high-quality things that you don't see sold over the counter at Office Max. They can be remotely controlled if need be. We can adjust it on us. We can adjust the patient's camera on their side. Dr. Klotz and I would just sit here, quite honestly, very casual, very laid back, just writing up our notes, seeing the patients. And right outside this door, we had Krystal, who is doing, honestly, all of the hard stuff that none of us really ever wanted to do. Checking the patients in, making sure all the logistics are set, making sure that patients are prepared for their visit. If there's an issue, communicating with the site to help either navigate or figure out what their technological or patient barriers are in getting those resolved. It may seem like something that's maybe not critical. I cannot emphasize enough. I think what Krystal does is just as important as what we're doing in the rest of telemedicine and telepharmacy, and actually ensuring that this is logistically happening the way that you want it to. All right, let me see. I do have a quick question here. How does credentialing work with pharmacists working with patients in other facilities? So of course, this is going to be the big question. It differs from location to location, even state by state. So there's about, if I remember the last time I looked, about 11 to 15 states that do have very specific legislation about telepharmacy and how this can be done, what is necessary. But quite honestly, depending on where you're coming from, it could be that it's the Wild West and there's really nothing in existence yet for how you can do this. I will talk a little bit more about this question later in terms of credentialing and pharmacists with other facilities. But I do want to highlight when I get there, these programs already are in existence. So being in this world, I'm not aware of these programs, but there's a number of programs that are already out there directly providing care to patients right under the noses of, I think, most physicians, most other providers in their brick and mortar clinics. And the quality is variable, which we'll talk about, but I will circle back to that. So already it's happening. All right, so then to just make everything look as depressing as possible. Now, post-pandemic telemedicine. So here's Krystal and I waiting for Dr. Klotz. This is our team Zoom meeting. This is me in my secret COVID bunker. You can tell by the dark lights, the mysterious look. I promise we're all very happy doing this, but I think just to summarize early on, the struggles of figuring out, is this even a thing that we can do on our own? Or are we just dead in the water without actually having access to some of these technologies? So how do I actually do this setup? And again, this is for you all to extrapolate. This is easy to do. You can absolutely start doing this based on the setup you likely already have. So I use two different computers. One's the laptop I'm talking to you all on right now. It's nothing fancy. And I've got my desktop set up. So why I use two computers is this laptop is dedicated to hosting our personal Zoom meeting. So we're part of University of Arizona, we do have a HIPAA level grade Zoom that we can log into and use. So Krystal, Dr. Klotz, and I can all be joined in on this one visit to keep in touch with each other while also going into other visits. And the reason, again, for the second setup is it's very rare that a computer can actually split the feed when one application is already using a webcam. Something that we very quickly discovered was going to make our lives miserable. We didn't figure out a solution. So I think Krystal can talk more about it. It's as easy as you can be on your phone and join in on this Zoom with it. So I've typically got the Zoom running. We can have students, medical, nursing, pharmacy, anyone that's involved can jump in on this Zoom and have an over-the-shoulder view of what's going on in the clinic. We've had a couple of hairy incidents where unfortunately Dr. Klotz's internet completely went out. And it was as easy as, bringing the computer closer, and while the audio wasn't the greatest, we were still able to implement that backup and have the patient be heard, have the provider be heard to the patient. Now, the camera that I typically use on my desktop did spoil myself a bit. I got a 1080p high definition webcam, ran me maybe 75 bucks off of Amazon, certainly well beyond anything I would ever need to do this job. And just highlighting this technology is easily available and you don't need fancy stuff to get started. Now, lastly, I do want to emphasize that we're typically on Microsoft Teams, Krystal and I, because again, while we're doing telemedicine, we're doing about a million other things with our routine jobs that we can go more into in this slide here. So in addition to our duties for telemedicine, we still have a brick and mortar clinic that is up and running 8 to 5 a.m. Monday through Friday. We have our patients coming in, and this can be your telepharmacy or telemedicine patients as well, who need something that just can't be provided over the computer. Whether that be, in our case, it's typically vaccines. We do also offer sexually transmitted infection treatments in our clinic. So each morning I'm checking those nursing visits, seeing what's needed for the patient, and I'm placing those orders as appropriate. In addition to that, I'm managing refill requests as they come up for our patients living with HIV, insurance issues. Of course, there's just no getting away from this nightmare. Coordinating that either with the pharmacy, which I'm also on Teams with, or with case managers who, again, are reachable through Microsoft Teams. And again, it doesn't need to be Teams. You may use Skype for Business. There's a number of other programs that are out there that institutions will use. Again, we're also doing inpatient issues. So to some degree, we're already trying to bring telepharmacy about in small doses to a lot of different areas. Inpatient issues, we have folks admitted living with HIV. A list is generated each morning that is sent to the pharmacist so I can review. Anyone is flagged that is having an ICD code related to HIV or a medication related to HIV gets added to this list, and they can be reviewed inpatient. I can place notes. I can get in touch again through Microsoft Teams with floor staff and implement some of these changes. Lastly, even during the pandemic, I think the biggest issue was, well, how are we even going to survive doing the day-to-day? After a few bumpy starts, then everything shifted back to normal. We were still able to accommodate students wanting to learn, bring them into this telepharmacy setting, see how it's done, let them be a part of it. All right, so I'm going to turn this over to Krystal, who's going to talk more about her role and what she does to make telepharmacy a reality. All yours, Krystal.
Okay, so for my preparation for clinic, it's actually kind of a lot to do when you think about it. I didn't really think about this when I was putting this together for Larry. But so for our telemedicine, we meet the third Wednesday of every month, Wednesday morning. And depending on how many patients we get for that clinic, we may need to move it to the following week, which we would do Thursday afternoon for Dr. Klotz. So the beginning of every month, I am reaching out to the prisons. In Arizona, we do 3 major prisons right now. We were doing more, but contracts are kind of being worked out. So I reach out to every prison asking, do we have any patients that need to be seen? If so, can you please send me their records? That goes into waiting here because they need authorizations, they need to get clearance. Once we get those, the second week usually of that month is when I request the records. Okay, can I have your records? I need authorizations. I make sure they're added into our EMR system because in order to have that telemedicine clinic, we need to have a profile for them. So we have to put their demographics. We need the authorization so that they can get, because Banner would need to be paid. And that's the other thing, is making sure you have that information for the billing. So every inmate gets an authorization code. It has to be put in, making sure all their demographics is updated, creating an encounter for that appointment. So making sure everything's marked, making sure the authorization for that specific appointment is on the encounter, because there's been times when there hasn't been an authorization and then they come back like, how is this being paid? And then it's a big old deal. So it's really double checking everything, making sure authorizations codes are there, making sure we received all the records. I'm going through them. Did we get labs? Did we get imaging? If it's an HIV patient, we look for labs, we look for their medications, specifically viral loads, CD4s. For other ID visits that we do get, I try to see what the issue is and then go into look into those records. Did we get imaging? Is it for an abscess? Is it, depending on what the case is. So we have to really review those records. Once we receive those, I send them out to Dr. Klotz and Larry so that they can review. I don't want them going into day of clinic and like, well, what is going on? So getting those records emailed out to them is the other big thing. Sometimes we have issues because we get such large files that we can't send. So then it's trying to figure out, okay, how do we get these over to them to review? Making everything remote has been a little bit easier because everything is sent electronically to me. So once I receive all the records, everything gets sent to them. And then from there, we can send it to our MAs so that they can be scanned into the charts for the patient. A lot of our patients do get seen either every 6 months or they come back with follow-up. So we have those records in the chart as well. Once our patients get seen, I'm the one checking them in. I check them out when they're done. Like Larry said, we have had some instances where the patient isn't ready. With dealing with different prison sites, the prisoners aren't always on the same yard. And so it's like we could have a patient at 9 o'clock and like, oh, well, our next one isn't here yet. We had to go to a different area to get him. So sometimes we can be waiting half an hour, 45 minutes for the next patient to get there. So for me, I'm in the background. I'm reaching out to the different facilities. Is your patient ready? Yes. Okay. Dr. Klotz, we can go to this one. We use Centurion, which is the portal for all telemed. And that is really nice because the prisons go ahead and create their profiles for their patients. They're assigned to Dr. Klotz, and then we can just go into that profile. So I can tell Dr. Klotz, oh, we're gonna go and see someone from Perryville prison right now. And then once we get done, we can go to Tucson prison. So we're easily able to flex and go to different sites, which is nice. Before, when we were in person, we actually had to disconnect from the monitor and disconnect from a certain site and then reconnect to another one. So it was actually harder to transition from those. And now it's easy. It's just one portal. We can go into it and scroll. So making sure everyone's checked in. Once they're done, checked out, I have to, at the end of that day, I'm typically waiting for the reports because, like Larry said, sometimes they're changing medications on hand. A patient can be on a medication and Dr. Klotz and Larry can be like, yeah, we may need to stop this. There's no need to. So it's making sure that we get those reports printed out and faxed over to the prisons so that they stop those medications or that they stop doing whatever they're doing. So a big thing is making sure that we get all these reports sent over to the facilities, because then they're like, oh, well, what are we going to do? They need those reports so that they can either stop the medication because their doctors there won't stop it, as well as the nurses. Like Larry said, when we are doing clinic, there is a nurse that's with them to do vitals, to help with the cameras. So as soon as we're done, everything gets sent over so that they know what to do, and then they have it for the following month.
Okay.
As far as post-clinic, like I said, it's just reviewing everything, sending every report over to them. Sometimes we have issues with the fax machines. Their fax machines are down. So then it's sending secure emails, making sure that everything is protected because of HIPAA. We also make sure the facilities did receive those reports and make sure they know patients should be seen next month. So we make sure that we have them on the list to get in next month. Sometimes we do have patients that are scheduled, but they refuse the day up, which is fine. We cancel that appointment, and sometimes we get them the following month, and we just use that same authorization and we get them going. But once everything's done, everything's in Cerner, which is nice, because then we can go back and like, oh, we saw this patient last month, we changed this, we did that. So it's just making sure that everything's in one location that we can easily access it. I can access it, Dr. Klotz, Larry, which makes it easier instead of like, well, you have to go look for here, or, you know, looking through charts, which when we were in person was a little bit harder. So now everything's just easy to go.
Yeah, all right. So getting a bit more into PrEP telepharmacy. So this is one of our next big ventures that we're really looking to get into and get started. We were just about to pull the trigger on this, and then of course COVID hit and ruined a lot of our plans. Is we had designed this to be a research project so we could actually publish and try to bring some sort of notoriety to this to try to get it more readily implemented. But my background's infectious disease. Certainly there's plenty of other ways you could start with this: hypertension, diabetes, dyslipidemia. But for what I would identify as low-hanging fruit for telepharmacy, I think PrEP easily is one of these options. And I won't get all into depth about this, and I guess this is more of a sales pitch on doing more PrEP, but how this can apply to telepharmacy. Why I would identify this as low-hanging fruit is PrEP is a medical intervention that has such insanely regimented and clear guidelines that you could essentially program somebody to carry out the necessary interventions, ask all the appropriate questions, and feel comfortable that they are getting the same experience as if they were seeing a provider or a physician, with, of course, notable exceptions, maybe particular infections or, you know, dermatological findings, what have you. But with PrEP, we actually just saw another update right at the end of 2021 that saw the PrEP guidelines get a major overhaul, and it even further simplified the idea of pre-exposure prophylaxis. So again, just to emphasize what PrEP is this is a preventive option for folks who are at high risk of acquiring HIV, whether it be through high-risk sexual practices, maybe it's multiple partners, infrequent condom use. It could also be unsafe injection drug use practices that could absolutely be worthy of discussing PrEP with someone. And this is something that is being targeted now inpatient at many hospitals. So again, with PrEP, it's very clear. There's only a few options that can be implemented. So to mention a couple of products you may have heard about, Truvada, which is now available generically, was the standard for PrEP. In the last 4 years or so, we saw Descovy, which is sort of an updated PrEP. It's essentially the same medication as Truvada with some kinetic differences. And then just recently, we saw the approval of the first long-acting injectable, not only for HIV, but also for PrEP. And with the data that's available, not only does it look like it is potentially the best option in terms of reducing the risk of HIV acquisition, it's easy to do for patients, and it features, again, an extra need for someone like Krystal to help with some of the logistics, and an added role for pharmacy to help get authorizations, approvals as needed. Another piece, though, of PrEP is sexual risk reduction counseling. This is a key piece of these typically every 3-month visits that are being carried out. So what I did when designing the program for TelePharmacy for PrEP was I came up with as specific a script as you could imagine. I wanted to, I trust Dr. Klotz. I think he trusts me. But as a pharmacist, I want to make sure that folks are understanding. I want to earn your trust. And on this role with TelePharmacy, it was creating as specific a document as I could, so that essentially I was advertising for myself, and you knew what product you were going to get if you were to have a pharmacist co-managing these conditions. You would see exactly my thought process, the logic trees, the questions that would necessitate further interventions, everything that you can imagine, in addition to performing those pharmacy services. As with PrEP, it's an often overlooked issue, but Descovy, even though it's virtually the same medication as Truvada, actually does have some game-breaking interactions that are, again, very easily overlooked. And even in our routine HIV clinic, recently had a patient who acquired HIV despite using PrEP because they were on, of all things, an over-the-counter supplement that broke Descovy. So again, key issues that are very easily overlooked. So it's implementing that pharmacy knowledge with the guarantee of what's also going to be offered at these visits. All right, so no need to go in depth with this. This is basically a one-stop shop page in the most current PrEP guidelines. Here's exactly what you're going to order, and here's exactly when you're going to do it. All of the things that you need to consider can essentially, 95% of it is summed up right here in terms of how can you have anybody come into your clinic and carry out this visit. Now, I see that Dr. Klotz, you answered that question about different licensing. That is to address then different facilities, but I want to draw attention to these programs already exist, and I don't think anybody knows about them other than patients. So PrEP, and I'm going to talk a little bit here too about PEP, which is post-exposure prophylaxis, which in a sentence is the plan B of HIV. If you've had an exposure and you're worried about acquiring it, there is something you can do. I very recently discovered that even PEP is now offered through telemed, telepharmacy services. And not to already try to, shoot myself in the foot with these telemedicine services, but I think there's two big issues here that I want to touch on. Clearly, the pandemic economically left a significant need. Patients were not as willing to come to clinics. There's several patients out there we can easily argue weren't already willing to come to a clinic, but certainly with COVID, that number absolutely blew through the roof. Both younger folks and older folks who didn't want to put themselves at any unnecessary risk that they didn't have to. I'll completely admit I haven't gone to a dentist in like 2 years because of COVID worries. I don't want to go somewhere if I don't absolutely have to until this issue has been resolved. And I think now that telemedicine is here, the cat's out of the bag. People can do this. So with this vacuum, I think you had a lot of opportunity for just about anyone to start to fill the sphere of telepharmacy and telemedicine. And again, I think with a lot of things, there's not a lot of quality control standards there other than, hey, we're offering this very specific thing in a way that you want it. It may not be the best way to do it, but it's being done. So issues that we've run into what I have personally experienced is with telepharmacy PEP, where patients were being prescribed these medications without any monitoring, no labs were being done. There was essentially no follow-up on the part of essentially the provider service or whoever was running this. And again, it's not to highlight the dangers of telemedicine. It's more that I want to stress, if you all are not willing to get involved in telepharmacy or telemedicine, somebody is, and they could potentially be stealing patients that could be coming to your clinic, offering services that frankly may not be up to par to what you're already able to provide. So again, another, I guess, trying to implore that do consider telepharmacy as a potential option, as these services do exist. And under your oversight, you can at least keep a handle on what's being done and control the quality and the type of care that you want to see delivered to these patients. So our plan specifically for PrEP telepharmacy, we wanted to open this clinic as a study, as I had mentioned, and everything had been drafted. Vaccine recommendations, when, where, what. STI treatments in concordance with the latest CDC guidelines for specifically gonorrhea, chlamydia, and syphilis. And then of course, our direct PrEP management. So I now want to, the last bit here, because of course I'm breaking my promise, or I'm sure we're going to run real close to time, is general applications for telepharmacy. Now, medication management services have been in existence since 2000s. And this is something that has been done for years that I don't think many people are aware of. Now, if you aren't aware of these services, the University of Arizona at one time was heavily involved, and then this model got set up elsewhere. And working with potentially benefits programs, highlighting patients who may be receiving a certain number of medications, essentially using that as a metric of high need for intervention, as if there isn't something that's taking place, either polypharmacy or poor outcomes, there could be an issue there. So medication management services were proactive in using this data to reach out using pharmacists to have these essentially cold call consults where patients' medications were reviewed, recommendations were made, messages could be sent off to providers based on the patient request, and issues could be improved on. And again, this is something that if the patient doesn't speak up, most providers, I don't think, are aware. This is something that's already been going on for years. We are now seeing uptake more worldwide. So medication management, there's even a new study out of Saudi Arabia in the last couple of years where COVID forced them to essentially adapt their own medication management model, where using their EMR, it was at a Johns Hopkins, I believe it was Epic, and they were using their MyChart. Patients could just dial into their MyChart through an app on their phone, reach a pharmacist at any time, and have this review carried out. And then things could be escalated to a provider as needed. Notes were then written, also sent off to the provider for review. So everything was done transparently. And again, we're translating what's already happening in real life to a virtual setting. Because, whether we realize it or not, pharmacists are still first line. Now, retail pharmacists may not have the same level of training, but they are first line for folks to get in touch with, ask their questions to. Just a quick search on PubMed, there's a number of articles. Now, unfortunately, we are still early in this era of how to actually set it up, having some hard metrics. So most of the studies that you're going to find are, hey, this is how we did it. Here's how you can do it too. And there's a lot of, surprisingly, specialization. Oncology telepharmacy. We're already doing HIV telepharmacy, a number of other disciplines, beyond primary care like diabetes are already using this model. Now, the last piece of this is, of course, inpatient telepharmacy. I think we have now a unique opportunity to support enhanced care. Now, there may be some folks present today who already are working in a hospital where this is done. Strangely enough, we're not seeing this typically done is often at our bigger hospitals. It's at our much smaller facilities in rural settings that have a clear need for having access to somebody when nobody can be present physically on site. So my background, I did a lot of work through the VA hospital system, And this is something that's employed there. Some of these smaller VA hospitals do not have on-site pharmacy staffing. So overnight, there is a centralized pharmacist that may be managing 3 different hospitals, for example, and they're already directly reachable, whether by phone or video, to have some of these questions asked of them. And of course, verifying medications, which is an easy use of telepharmacy, just having folks sitting at home verifying medications there. There's also then here an issue where we can have the specialty pharmacist services available not only to any providers on the floor, but to specialty services where questions can quickly be asked either by video or by phone of pharmacists. And then lastly, this I think is not as easy to institute, but having bedside medication review, either from a pharmacist that you're affiliated with, whether you have one in your hospital, having maybe a tablet or something that's available where patients can just already knock out all this medication piece, a reconciliation can be done before the patient's even left the hospital. You can already know that they are safe and sound in terms of having access to those meds, counseling, and any potential med issues are already known and dealt with before that patient has left the hospital. So this could be prior auths. How many of us have used antibiotics that then we find out, oh, Linezolid is going to cost $1,000 for this patient? Getting those things dealt with early. All right, so key points here, and then we'll wrap it up and open it up for some more questions. How to set up a telepharmacy program. Of course, I'm viewing this through the lens of an infectious disease background, but I do think that this comparison is spot on. Antimicrobial stewardship committees. So go with me for this on a second. Clearly, we have tons of data that demonstrate this is absolutely a major benefit everywhere. Skilled nursing facilities, certainly hospitals, even in outpatient community settings, having some kind of oversight for antimicrobial use. And the key points here, how do I set this up? I need to prove that it works, which has been done. And with telepharmacy, that data is available that shows, no, you can absolutely translate some of these models to a virtual space. You need support from your administration. This can be, maybe this is you that needs to be convinced that this is something that's worth your time and having that buy-in. I think the key piece, as with a stewardship committee, is a multidisciplinary approach. That's the inclusion of pharmacy, people like Krystal who can help with all of the difficult issues that come up that frankly, I certainly have no idea what to deal with. I know Dr. Klotz doesn't. Having someone who's skilled with all of the legwork that is required to make these things happen. And of course, with stewardship committees, it's going to depend on where you are and what you want to do. That is one of the main issues, is all of these things. It's hard to give a very easy, here's exactly how to do it, because it's so unique to the site and the needs that you already have. We have a rather unorthodox setup that I think is fantastic, our collaborative care approach. That was an easy translation over to telepharmacy. That may be something that's a bit different for your needs. All right, barriers, again, hesitance to change current models. I think now that the COVID is backing down a bit, there's a lot of desire to just throw everything back to normal. And whether we want to or not, much like COVID, telemedicine's out of the bag. Telepharmacy is here and now, and if providers aren't willing to do it, there are people that are going to step in and do it. So in terms of making everything an economic choice, patients will have these options available to them that could potentially take away from your own practice if they see this other option. So there is, I think, a strong push, certainly from myself, to get involved so that we can also get high quality providers doing something unique. There's also, of course, always going to be a need for the technologies that are used. This is something that I think is key. There's only so much that I can do. I feel like I know more than I ever thought I would want to about Zoom. And I know poor Krystal has gotten stuck with this too. That there's going to come a point you need someone who is dedicated to being able to resolve some of these issues. All right, so in conclusion, telepharmacy, I think it's a natural extension of telemedicine. I think virtual space that already exists, so why not just translate everything we're doing in modern day to this virtual space out of a brick and mortar clinic. And I think, again, one of the key issues is I don't think people realize telepharmacy is already happening. Pharmacy-run clinics are already happening under these collaborative practice agreements with other providers. I think its use does free up providers. So co-managing chronic conditions, you see the patient diagnosed with diabetes and maybe start them on insulin. Well, of course, this may require frequent check-ins to get that dose just right. You now have someone that you can just say, hey, get this guy's insulin dose to where it needs to be. Done. You can have a pharmacist that exclusively manages that. The technology, again, there are some high-end materials out there for doing this in an incredibly sophisticated way. But if you want to get started, we are doing this with, next to Cracker Jack type stuff. Things I've ordered off Amazon.com, and we've been running for a couple of years now on this equipment, and it's been to success. All right, so with that, we've got about 4 or 5 minutes for questions. So let's see here. I think Dr. Klotz answered a couple here. Let's see.
Larry, could you address, there are several questions about the Bureau of Pharmacy for Arizona. I assume that's what BOP stands for, and also some other issues up above, several that I did answer.
Let's see here. I am looking right now to do some quick catch up. No, you guys are writing novels in the chat. Holy moly. The mouse is looking real hard on me.
For the
Okay,
answers,
so let's see.
for the answers, we just need to make sure we hit everyone so everyone can see the answers in the chat.
Oh, for the replies.
Yes.
I see what you're saying. So I think folks that have asked the questions, Dr. Klotz has answered them. I'm going to try to do a quick copy paste for you so that you all can see them. So this right here, let me switch here, is addressing, so the first question, how does credentialing work with pharmacists working with patients in other facilities? This is Dr. Klotz's response to your question. Okay, we've got that one. And then I see Melanie, you added in there. Okay, reviewed AZ Board of Pharmacy rules around telepharmacy. All right, very interesting process. Harry documented telepharmacy visit for each individual patient's records. Can we discuss reimbursement available for Medicare and commercial payers? So for the rules around telepharmacy for Arizona Board of Pharmacy, we have taken a look at it's almost its own discussion to make sure we go through all of the specifics, as I did want to keep this more generalized if we had folks joining us out of state. But we can address that if we do have a little bit of time. If not, our contact information should be available in the slides, and we can address that one for you. Harry documented the telepharmacy visit in each individual. Okay, so that is a unique one in terms of individual patients' medical records. So what we're doing is the slides will be posted. So for that fellow that answered that question, no worries, that they should be available. And Melanie can get you all the details for that. Okay. Yeah, the chat keeps moving on. Or my eyeballs are scrolling. I don't know what's happening anymore. There we are. Okay, reimbursement. So as far as the reimbursement, let me see if Dr. Klotz, I will turn that one over to Dr. Klotz, who has been working more to get all of that piece set up in terms of reimbursement available from Medicare and commercial payers. So Dr. Klotz, are you comfortable answering that question? Okay, I'm going to do that one.
Well, sort of, Larry. We, through our billing system and our EMR system, which we use for all our patient visits, and which the pharmacist and the clinical coordinator, like Krystal, write their individual notes, there's an overall charge for the whole visit. And it's currently, what's happening is that the state has decided what will be the remuneration for telemedicine. But because all of us are on federal grants, which is not where all of you are, but we do have one advantage is we can decide what we want to do with our lives and medicine and pharmacy. For you individuals who are working for hospitals or physicians and so forth, you're going to have to work with them and decide how you're going to be able to be remunerated for your time involved with telemedicine. So right now, I don't think there's any guidelines that I'm aware of. There are for telemedicine visits, but with telepharmacy, I think it's just a matter of each individual deciding, well, this is so darn important and such an easy way to keep people out of the hospital that we're going to do it no matter what. And we'll figure out the pay later, I guess you might say. Does that answer it, Larry?
I think so. Let me know in the chat if that answered your question, or if that at least got you in the right direction. I think there was one other, yes, so other HIPAA compliant telehealth platforms, there's a ton of them. The one that Banner typically uses, I think mostly a homebrew that's called eVisit. Doximity is something that you can also employ. I have a Doximity on my phone, and you can do video visits through that as well. So there are a number, and that, I even hate to say that, that would be its own presentation too. There's a ton of different services out there that you can either pay into to be a part of. So Centurion, the unique aspect of that service is they do have the programming to manipulate the camera on the other end that you can then manipulate or adjust that to suit your needs as they would come up. There's a ton. I think there's other popular one I think is called Blue Jeans or something like that that I've heard come up.
The other thing with the Centurion platform that we use with the prison is not only are we able to control the camera, they can control the camera, but it's also able to record the visit. If for some reason, like the provider would need to go back into the visit or to do their notes, if maybe they missed something, you do have the availability to record your visit, and then you can assign your provider or assign the patient to that specific provider. So when we log into our Centurion platform, we can see for telemedicine, we can see for psychiatry, they have other different platforms. So you can actually go to locate your patient, not only on the location site, but by their name.
That's a good point. All right, any other questions from y'all? We are a bit over time. I tried.
So I did put into the chat the URL. The recording will be available on our website later. And if you have any other questions for Dr. Klotz or Larry or Krystal, by all means, you can either reach out to them or you can reach out to me and I can get those questions forwarded to them as well. So with that, if we don't have any more questions, I'd like to again, oh, one just popped in.
Oh, let me open up.
Sorry.
So message ASHP has a new telemedicine certification program coming. Very cool.
Okay. All right. So with that, again, thank you, Dr. Klotz, who is joining us from far away. And thank you to Larry and Krystal. And again, please check our website for future programs, and the recording will be up a little bit later. Thank you, everybody.